pleased to welcome Sue Imbriglia, who will discuss physical and occupational therapy for Huntington's disease. Sue Imbriglia is currently the program manager for the Huntington's Disease Research Clinic at the Mass General Hospital in Boston. She was formerly the director of rehabilitation at Lowell Healthcare Center, where she treated patients with Huntington's disease for the past 23 years. Sue is the author of the HDSA Family Guide series, Physical and Occupational Therapy for Huntington's Disease. As a member of the neurology section of the American Physical Therapy Association, Sue has served as a liaison between the Degenerative Disease Special Interest Group of the APTA and the Huntington's Disease Society of America. She is also a member of the HDSA National Field Committee and serves on the board of the Massachusetts chapter. Before I invite Sue to begin, I would like to go over how to ask a question, as well as how to access this webinar and other webinars. You can send a question at any point during the presentation. However, we will answer questions during the last 15 minutes. To send a question, go to your control panel that appears on the right-hand side of the screen. You'll see a panel for typing in your question. After typing it in, just hit the send button. You'll also be able to view this webinar again after its broadcast. Approximately 1 week after broadcast, you'll be able to access it on the HDSA website. To access this presentation, just go to www.hdsa.org and scroll to the home page where you will see a shortcut for the webinar. There will be an accompanying PowerPoint presentation as well as the PDF for the slide. You can also access older webinars in the Living with HD section. And now I'm pleased to welcome Sue.
Thank you very much, Jane. And thank you very much to the HDSA for inviting me to participate in this webinar. The content of the webinar is based on the booklet that Jane mentioned, and that is available through the HDSA. Over the years, I've received very positive feedback from therapists who have had little or no experience treating people with Huntington's disease, who have used this booklet, and it was given to them by their family members. So I hope that today's listeners will also find the information useful. Before we begin, I'd just like to define a couple of things. Throughout this webinar, I'll use the terms early, mid-stage, and later stage. And I usually define those by early. People are diagnosed but maybe still be working part-time, doing most of their ADL care by themselves, and still functioning at a pretty high functional level. Mid-stage folks usually require more assistance, are needing assistance for a good number of their ADLs, and are no longer working. And later stage folks are usually people who require full-time consistent care. The motor problems that people develop through Huntington's disease are many. However, you need to keep in mind that not everyone has all of the problems that we're going to talk about today, at least not all at the same time. However, for purposes of education, we're going to talk about a lot of different problems that you will see throughout the course of the disease process. So I don't want to frighten people to think that, oh my goodness, we're going to have all of these things all at once. That's not how it works. But I do want you to be knowledgeable about some of the issues so that when you are seeing them or faced with them, then you can get the appropriate help for these issues. The movement disorder is characterized by impairments in both voluntary and involuntary movement. We're going to start with the voluntary movement disorder and look at three components of it. The first is akathisia, and that's a delayed initiation of movement. People usually recognize this by the person who is affected with HD as having difficulty getting started. A common report from families is the person sits down at the breakfast table, stares at the food, and doesn't pick up the fork or spoon. And it isn't until the fork or spoon is placed in their hand do they start to eat. So that that is a signal of delayed initiation of movement. The second, bradykinesia, is slowed movement. And we see that most often in people's rate of walking or their speed of walking. One of the things that we notice, and that has been actually studied fairly extensively by physical therapists, is that people with Huntington's disease, their rate of walking is slower and becomes even more slow as the disease progresses. Bradykinesia can show up in other movements as well, but those other movements haven't been studied as much as walking speed has been studied. And the last one, incoordination, which is an alteration of rhythmic movement. A lot of people identify this with the test that the neurologist does of touch my finger and touch your nose. The neurologist holds their finger up and you have to touch their finger and touch your nose and do this repeatedly. And what the physician is looking at is the path of the movement, how accurate is the movement. And people who have problems with incoordination and an alteration in their rhythmic movement have difficulty with things like buttoning, placing a key into a keyhole, threading a needle. So that's where incoordination shows up most. The movement disorder also has problems with involuntary movement, and chorea is the most common, what most people recognize as being involuntary movement in Huntington's disease. The chorea is the Greek word for dance, and the involuntary movements are very rhythmical, often dance-like, can appear in all major muscle groups, including the tongue. It can appear in the diaphragms, causing inadvertent breaths. So chorea can be very problematic. What's interesting, though, is that many people who have chorea are not aware that they have chorea. And when chorea is minimal or even up to moderate, generally we don't treat chorea. We're fortunate now that people who have severe chorea or whose chorea patterns of movement become self-injurious, we have medication now called tetrabenazine or xenazine, and we're grateful to Lundbeck for getting that available to us now in the United States. But the tetrabenazine or xenazine has been proven to be quite successful in treating people who have excessive chorea. But the majority of people are not truthfully bothered by their chorea, and we don't usually develop treatment plans for that. Akathisia, or motor restlessness, a person with Huntington's disease often describes this as being supercharged, not being able to sit still or stand in one place. Frequently, they describe it as always having to have some movement going on. And this is not the movement of chorea now. This is just a kind of movement of the feet or movement of the whole body, not being able to sit still. Dystonia is abnormal muscle tone, usually asymmetrical in Huntington's disease. So one side of the body versus the whole body. And it causes some difficulty in posture. So the person's head may tilt to one side, or the upper part of the body may bend to one side, or one arm or one ankle might have abnormal posture causing some tripping. So dystonia is quite problematic. and we'll talk about some strategies in a few minutes on how to deal with some of these things. The inability to modulate force of movement is quite difficult for people. It's often misconstrued as behavior, and to those of us whose nervous system is intact, we do not have to even consider picking up a glass of water, for example. We don't have to consider how much force it takes to lift the glass or place it back down. That our nervous system just responds automatically, and the right amount of force is used, so we don't break the glass when we put it down, and we don't crush a paper cup when we pick it up. But the person with Huntington's disease is unable to modulate that force of movement. So sometimes they go to pick up something very light and use excessive force and crumple it. They go to shut the door and it slams instead. They go to stand from a table. We would push our chair back and the chair tips over because they can't modulate that force. And so it's often misconstrued as the person's upset or angry or something else is going on, but it's clearly just a involuntary movement problem in which they can't modulate the amount of force taken for the movement. And lastly, motor impersistence occurs. A person might be trying to hold a spoon and eat, and the muscles just stop contracting so that the fork or spoon drops from the hand. It's a very frustrating event when it happens because there's no warning and the muscles just let go. So a person, and again, none of these things are happening throughout the entire course of the disease. However, they do happen with enough frequency that people may recognize these issues and may want to seek assistance for when they do happen. In addition to these troubling voluntary and involuntary motor problems, we have some common motor deficits that arise as well. Muscle weakness is apparent pretty early on in the disease when people are diagnosed. Upper neck and shoulder region becomes weak. The trunk, particularly the muscles of the abdomen, become weakened, and the small muscles of the hands and feet. So typically the person presents with a forward head, a small paunch where none was apparent before, so that the abdomen is protruding a little bit, and some wasting of the muscles of the hands and feet, which contribute to difficulty grasping things. And when it's in the muscles of the feet, we see people who have difficulty on uneven terrain, or if their balance is perturbed, someone knocks into them, they may have difficulty recovering their balance because those small muscles of the feet really work to help us keep our balance. Additionally, we see balance problems based on slow reaction time and poor postural control. So some of that muscle weakness that we just described in the trunk contributes to poor postural control. Generally, the balance disturbance is very subtle and starts very slowly, but by the mid-stage of the disease, people are having a lot of difficulty balancing on one foot, for example. They're no longer able to balance on one foot. So when you go to turn suddenly, if you can't balance on one foot even for a few seconds, then that's going to lead you to have falls. Visual spatial problems are apparent. This comes from the person's difficulty in visually scanning. The eye movements are slowed, and therefore the person has difficulty scanning the environment, noticing that things are coming into their environment, and therefore they tend to bump into things. Also, depth perception may be impaired, and people will have falls from not being able to judge the depth of a step or how far away they are from a chair. And lastly, unawareness of fatigue. When we talk about MS, multiple sclerosis, people automatically think about energy conservation because people with MS are very aware of the fatigue that they have in their muscles. Unfortunately, people with Huntington's disease are not as aware, and I like to describe people with Huntington's disease as the Energizer bunnies. They're usually moving all the time and never stop, but this unawareness of fatigue very much plays a part in problems down the road, or even in one particular day, because the person is going to have much more muscle fatigue that they're not going to pay attention to or not even notice, and then cause falls or difficulty with muscle performance. So, how can physical therapy help? Well, first you have to find a PT. And I've heard some really disturbing stories from family members where they are not able to find a PT, or they find a PT and the person really has no neurologic experience. They're a sports PT or they're a generalist, and really have not been able to help the person with Huntington's disease. One thing that the American Physical Therapy Association, or APTA, has done is they've afforded a link, or provided a link on the APTA website that says find a PT, and within a particular radius you can go in and find physical therapists, and their specialty is usually delineated under their with their practice site. So I urge people, if you are looking for a physical therapist, this is one way to contact one that may have some, at least, neurologic experience. They don't necessarily have to have Huntington's experience, but if a person has had neurology experience, has worked with people with Parkinson's or other neurodegenerative disorders, they're going to have a much better understanding of the needs of somebody with Huntington's disease. So how can a physical therapist help? Well, generally the physical therapist is going to perform an evaluation that will look at what's happening now, but also it's important to know what has happened in the recent past, because that's going to give the physical therapist, some information about what the person's capabilities are going to be. Also looking at the person's medications and side effects, because we want to make sure that some of the physical problems that the person's presenting with are not related to medications. And certainly how the person has been being cared for, or with their social situation, their living situation, and whether there are any restrictions that that person may require. The evaluation usually consists of looking at some of the things that we've just talked about in terms of neuromuscular issues, the chorea, balance, and bradykinesia, but also musculoskeletal issues, posture, range of motion, strength, and cardiorespiratory assessment, which is very important in Huntington's disease. So in developing strategies for people in the early stage of the disease, strengthening muscles of the core, that's a kind of a buzzword now. Everybody wants to do core strengthening. That's usually considered the abdomen and back muscles. Those are the muscles that also do help with maintaining balance. So if you go to the gym and you're not at a stage yet where you want to enlist a physical therapist, but you can go to the gym and talk to the personal trainer and say, I need exercises for my core. That's going to help with those the postural muscles. Those are the muscles that are going to keep you upright, try to remedy some of that abdominal weakening and upper back weakening. General strengthening for major muscle groups is important to just keep all of those muscles strong. Advanced balance activities. These are activities where if you're in a routine gym, a regular health club type gym, you see people practicing walking on a one foot in front of the other, balancing on one foot while they're holding weights. Any of those kinds of activities are going to be very useful for people in the early stage of the disease where you're really maintaining your ability to balance on one foot. That's going to help with uneven terrain outdoors and really prevent falls. And then, of course, maintaining aerobic activity for heart and lung function. The stronger we maintain the heart and lungs, the better it's going to be down the road when swallowing becomes a problem. If our lungs are in better condition and we can take a deep breath and clear the airway, then we're going to prevent choking. So keeping aerobic activity as part of a general routine is important. As the disease progresses, cognitive issues become apparent. And if the person is meeting a physical therapist for the first time and the physical therapist doesn't know too much about Huntington's disease, it's important for them to understand that there may be some difficulty learning new tasks or strategies. I hear from physical therapists very often, they say, well, I gave them a home program and they didn't go home and do it. Well, if the person has difficulty learning new tasks and new strategies or problems with their memory, they're going to have a much more difficult time, and they need to have strategies in which to help learn a home program. It's not going to just give them a paper and here we go. So educating the therapist to these issues is very important. The memory problem that people with Huntington's disease have is different from some of the other dementia-type diseases. This memory problem is related to the difficulty retrieving information. So the information goes in and gets stored, but the person with Huntington's disease has difficulty getting the correct information out. So it's similar to those of us, I'm of the age group where I have senior moments, and it's similar to those senior moments where you wake up at 2 in the morning and say, oh yeah, that's the answer. Well, it's a similar type of thing. The person knows the information, they just can't retrieve it. They can't get it to the forefront to get the answer out, which of course leads to a lot of frustration. Cognitive issues also involve problems organizing and problems staying on task. So again, the idea of handing a person with Huntington's disease a home program, a piece of paper that says, here, go home and do this, is going to be problematic. That's not going to be very successful because they're going to have more difficulty organizing that into their day and staying on task. So what are some strategies to help the individual both learn and stay on task? In order to learn, the person needs a quiet environment. The person with Huntington's disease is very distractible. They have a difficult time eliminating outside interference. So if a radio or television is playing in the background, that is going to come to the forefront, and they're not going to be able to focus on what's being said to them. So really providing a quiet environment is very important with learning anything new. Being concrete. Everything needs to be stated in simple sentences and and not be vague. Everything needs to be concrete. breaking up activities into simple tasks, simple steps is important to learn, and then once they learn the simple task, then the whole piece comes together. So these are strategies that help anybody learn, but they are very helpful to the person with Huntington's disease. As the disease progresses into mid-stage, we start looking at maintaining function now, and we want to maintain coordination, walking. Relaxation is really helpful in mid-stage, and also sensory awareness, keeping all of those difficulties that we talked about, the visual spatial and perceptual difficulties, keeping those on task. Now, in the mid-stage, chorea may increase, and this is when medication may be most helpful. It's interesting, not everyone has chorea, and a lot of people, it's a misconception that everybody thinks, okay, well, when is the chorea going to stop? But not everyone has chorea. So, but those who do, as mid-stage comes along, chorea may get worse, and therefore this is when medication is most helpful. Muscle weakness also gets worse, and changes in muscle tone. And this is when adaptive equipment or specialty equipment becomes really important. It's been my experience to utilize or introduce adaptive equipment well before it's required. So if a person is just starting to show some muscle weakness, having some balance problems, it's not a bad idea to introduce a wheelchair for trips to the mall or occasions when the person would normally be walking for long periods of time, and to introduce it as an energy conservation tactic. I think the more that people understand that it's to conserve muscle power and muscle energy, then it becomes a little more palatable. A lot of people are resistant to accepting adaptive equipment, but if they understood that for reasons of muscle energy and muscle energy conservation, sometimes it's a little more easier to accept. Same thing with using a walker. Introducing a walker well before the person requires the use of a walker means that they perfect the use of it before they actually need it, and it becomes much more beneficial. We also see at this stage balance impairments, where we mentioned before the person's inability to balance on one foot becomes only momentary, and they're losing their balance as soon as they make some kind of a turn. So what kinds of strategies are helpful? There's one strategy that I've used a great deal called touch, turn, sit, and it focuses on eliminating some of the visual spatial problems as well as balance. If you picture yourself approaching a chair or a bed, if you have a problem with depth perception, you may not get close enough to the chair before you turn to sit on it. But if you touch it, that brings you close enough. So touching the object that you're going to sit on, whether it's a chair or a bed, then turning. By touching and then turning, once you touch it, even though you're unweighting one foot, you still have 2 points of contact, which is very helpful for maintaining balance. And then sitting helps you automatically sit in the right place. As a physical therapist in a nursing home for many years, it was my job to look at where falls occurred. And very often falls would occur at the bedside or near a chair. And after investigating it quite a bit, I realized that a lot of times it was because the person was turning and trying to sit well before they were close enough to the bed or the chair. So this strategy really works, and you do have to cue the person for some time before it becomes automatic, but in doing so the person gets more success, and therefore they tend to try to do it themselves. Rising to stand is also a problematic area. People with Huntington's disease tend to, when they go to stand up, arch their upper body back, so their base of support is actually going back instead of forward, and they fall back into the chair. So one little strategy is to have them put their hands on their knees and bring their nose or head forward. And by putting your hands on your knees, you're pushing up on your knees. That automatically brings your body forward and gives you a better chance of success of actually standing up. We've mentioned use of walkers and wheelchairs. Seating devices, there are a lot of specialty equipment out there now, but generally it's making sure that anything that the person is going to sit in is padded, looking at seat depth to make sure that the low back and leg from hip to knee is supported. And also, this is a time when safety equipment comes into play, looking at the home environment, and when we talk about occupational therapy, we'll go into that a little bit more. In the later stages of Huntington's disease, the common deficits are difficulty modulating force of movement. We see that much more in the later stage, and we've already discussed how that can affect a person and be misinterpreted. In the later stage, it can, because there are other problems, chorea may be more apparent, and the movement is more rigid. This difficulty with modulating force of movement comes out as very, very large movements, and people sometimes have a great deal of difficulty controlling their movement. We also see worsening of muscle tone and some rigidity, so that the muscles become very stiff, the limbs move in only one plane. There's very little movement outside of a forward and back plane, and that can lead to some pain too. So rigidity is something the neurologist may want to treat. We see speech difficulties because the muscles of the face, the tongue, all of these muscles become impaired, both by weakness. Chorea can be evident, and also this difficulty in modulating force of movement. And nutritional challenges are apparent as well, because swallowing becomes impaired. The goal here for physical therapy in terms of the later stages is to address safety and comfort, making sure that the person is in their best optimum position for eating and for communicating. A lot of times people have an idea that they don't understand what OT does or how OT can help. And occupational therapists generally look at the person's ability to perform activities of daily living, or commonly known as ADLs. They are also able to do a comprehensive home evaluation, and in the early stage, job site evaluations. This is an area where occupational therapists are very valuable in going into a person's job site and assisting the client in making accommodations or making recommendations to the employer to help with accommodations. They also are very adept at providing adaptive equipment as it relates to the activities of daily living, showering, hygiene, And they're able to give guidance to family members and caregivers in terms of how to assist with these strategies for activities of daily living. In the early stages of the disease, we talked about how the changes in cognition may affect learning, but it also the changes in cognition also affect attention and concentration, initiation, and this now is like the motor component or akathisia. This initiation is sometimes in thought as well. Perseveration, impulse control, and irritability. Perseveration, I like to call it lock-on, because the person gets a thought, they lock onto it, and they have a very, very difficult time changing the set. It becomes very difficult for that person to move on from once that thought is in their head, and it can become very problematic for family members, because if the person is locked on to doing a particular task or requesting a particular meal, for example, the meal can be presented, but they can't get off that idea. It takes quite a bit to change that set of thoughts. And you really do need to change completely. You change the environment, change the setting in order to get the person to stop saying the same thing. Impulse control involves the person's inability to, even though they might know a drink belongs to someone else, a perfect stranger, for example, if they have the impulse to drink, they're going to take that drink regardless of who it belongs to. So it's the inability to use the gatekeeper that we all have in the brain to stop us from doing something that we know isn't necessarily socially appropriate, but the brain is not going to, that gatekeeper is asleep, and they're not going to be able to stop that thought. So if the thought is, I need a drink, and there is the drink, it doesn't matter whose it is, I'm going to take it, that's impulse control problems. So here are some helpful strategies for some of these cognitive difficulties. Establishing a consistent routine, regardless of what stage the person's in, is a very, very helpful tool, because we all feel better when we establish a consistent routine. So the more consistent the day, the less the person has to problem solve, the less they have to organize themselves, and they feel more comfortable. From a memory perspective, if you avoid open-ended questions, for example, what did you have for breakfast is an open-ended question. Instead, ask, did you have toast or cereal? Even if the answer is eggs, the person, by refraining from asking an open-ended question, you've given the person a hint or a cue as to what you need, or the information that you need. And 99% of the time, they can then come up with the actual answer. But if you ask an open-ended question, they're going to have a much more difficult time retrieving that information. Also, by asking questions that require only a yes or no response is going to facilitate communication. Offer hints and cues, use lists and label items in the home. Very helpful for people, even though they usually know where things are in the home. It's amazing, by putting little labels, sticky labels on the frequently used items, it allows them to not have to process that information, and they're able to fulfill a task much more simply. When giving information for the first time, like instructions on, for example, how to use the microwave. It's important to ask the person to repeat important points and also to break up anything that's got more than 3 steps into simple steps and practice the steps individually, then put the whole task together. An occupational therapist can perform a home safety assessment, and some of the areas that they look at are analyzing meal preparation and looking at the tasks involved in personal hygiene, looking at how the person needs to get from one place to another within the home, and looking at the need for adaptive equipment within the home. Here are some safety suggestions. And at times they seem very common sense, but a lot of times when you're in the situation, you don't always think of trying some of these. But these have been tested and tried and true, and really do seem to help people be able to function a little bit better and more safely. So in the kitchen, looking using unbreakable dinnerware. There's so many opportunities now for dinnerware that doesn't have any kind of, but like the Corel type of dinnerware, where people, it still looks really nice, but there's no, it's not going to break when someone drops it. Using only the lower cabinets for common items is very helpful. This way the person is able to still fulfill their jobs throughout the day, but they're not having to raise their arms up above their head, which is often a common problem. As soon as the person lifts any kind of object over their head, they're going to then set their balance backwards, and this is a common cause for falls. Using a kitchen timer as a reminder to turn off appliances really has worked very well for a lot of people, because that's one of the common complaints. They'll go on to another task and forget that they've left the stove or the kettle on. And once that timer goes off, it's a reminder to come back and check that. It doesn't hurt for the entire family to have the temperature of the water within the home lowered. People with Huntington's disease often lose the ability to judge hot and cold, and this can lead to burns. Even with cold, it can lead to hypothermia, so it's certainly something to consider. In the bathroom, oftentimes I get a laugh when people see soap on a rope, but this has been a very helpful tool for people. There's nothing worse than dropping a slippery bar of soap and then bending forward and falling in the tub because you're trying to pick it up. So hanging the soap on the faucet or a bar nearby really does work. The person can just soap up their face cloth and not have to be handling the soap. Shower benches and chairs are commonly used with the elderly and make for a very comfortable situation in the shower or the tub, so that there is the person is seated and don't have to hold their balance upright. In the living room, using chairs with high backs and arms really is best. Using something like a recliner works very well, and it has different changes in positioning, so that the person, if they're going to sit for any length of time, they're able to change their position without too much difficulty. In the mid-stage, people have difficulty with initiation, and we've talked about that a little bit. Fatigue is more prominent, and problem sequencing tasks, which often affect hygiene and dressing. We often see in this stage where people stop washing up and stop changing their clothes, and a lot of it is because they can't organize that and sequence those tasks, and they don't know how to ask. So if an occupational therapist comes in to the home and sees that, they can actually sequence those tasks for them, and then the person is able to actually do them. Once this task is sequenced, they just have to follow the steps, and they're usually very capable of following the steps. So here are some helpful strategies for these problems. Avoid asking. Instead, respectfully suggest an activity. That's if the person is unable to initiate. You say, come on, Mom, let's go to the kitchen, and Mom just sits there. It appears that she doesn't want to go. She can't say that I can't get up. She just needs that prompt. So instead of asking, just say, let's go, Mom, and prompt by either the shoulder or the arm, and the person then can follow the lead. Build rest periods into the daily schedule, and this doesn't mean the person has to actually lie down and sleep. It just means they do need to give those muscles a rest. If they're really on the go and you're noticing changes late in the day where the person is getting ready to fall or looks like their balance is worse, by putting rest periods into the day, that really helps to combat fatigue. Writing out lists for the person to achieve in the morning and in the evening really helps them, allows the person to continue to participate in the chores, but means they don't have to actually sequence the task. The list is going to do that sequencing for them. And if they're having difficulty changing their clothes and choosing items, by putting a pair of pants and a shirt on the same hanger so they don't have to make the decision, it really is helpful. They could just go, some people even go to the extreme of, here it is for Monday, Tuesday, Wednesday, Thursday, and just have it outlined that way throughout the week, and the person can just follow along. Then in the late stage, to prevent skin breakdown, it's important to establish a routine of position changes. Even though the person has a lot of movement, may have a lot of movement with chorea, that doesn't mean they're changing their position. And generally in the later stage, weight is a factor. There's less body fat, and that can lead to a lot of skin problems and breakdowns. So building and establishing a routine of position changes is important. Padding furniture to prevent injury is also important. Anything with hard surfaces, using pillows and blankets to prevent any injury. And preventing contracture, which is a shortening of the muscles. And we talked a little bit about range of motion becoming impaired. If the person never moves the arm or leg in the method at which it was intended, those muscles are going to shorten up and can become painful and rigid, and becomes a bigger problem. So prevention here is a really good strategy. And I think we're going to take questions. Okay. Okay, here we go. I had to figure out how to see the question, but I have it now. Hold on just a second. I'm going to read this question. I'm in the early stage HD, no chorea, but affected most by akathisia and dystonia, which has led to balance problems and muscle weakness. I have fallen down the stairs multiple times, but have found that the core muscle exercises are most beneficial. However, insurance will not cover balance therapy, and physical therapy is covered only a certain number of visits. My experience with the balance routine has been instrumental in keeping my balance and preventing falls. How can we convince the insurance companies that physical therapy by itself is not helping my balance issues? Has anyone figured out how to get a therapist paid for visits that are not considered part of physical therapy? I have found a perfect person for balance therapy I require, but I'm unable to pay the hourly rate for twice weekly visits. Any suggestions? It's true that insurance companies often put a limit, especially HMOs, put a limit on how often a person can receive therapy throughout a year. And it is unfortunate in that it is the way it is. But you're on the right track, Julie, in terms of you've identified what your problems are. A lot of times people can, now that you've seen a physical therapist, take that program and go to a Y or a gym and work on those strategies that the therapist has identified for on your own for several months in a row, and then go back to your doctor and look at, ask for a change, a visit change, so that you can go back to the physical therapist to look at additional strategies. But what happens is if you're going back and asking for the same thing, so another balance visit, you're right, they're not going to pay for that. The physical therapist and the doctor have to be a little bit creative in terms of what they're going to look at. So you need to change the reason to go back. All right, the next question, are table chairs with armrests better, or are chairs without arm? Okay, so the question is, are chairs with arm rests better? And they are, because it gives a little bit of support to the trunk when the person is sitting, even if the person is sitting at a table, and I think that's what they're referring to. The person who is sitting at a table to eat expends a lot of energy just focusing on the meal, getting the food to them, so that if they have a chair with arms, it's going to provide a little bit of support, especially if they have a considerable trunk movement. The pillows can be put on either side to make the person a little more stable, and then a pillow can be put in their back, to additionally make the trunk more stable, so that all they have to focus on is getting the food to their mouth, which is, of course, the reason they're sitting at the table in the first place. There's a question here from Bob. It says sleeping difficulty. I'm not clear on exactly what the question is, but sleeping difficulty is very common in Huntington's disease, and definitely if you are having difficulty sleeping, you definitely should talk to your neurologist. There are some medications that can help, and actually exercise is very, very helpful. A lot of people who exercise in the afternoon find that they sleep better once they've done an exercise routine. So exercise has been proven in a lot of populations to really be helpful in helping people to sleep. So it's not untrue with Huntington's disease either. Do you have a recommendation on a type of car that is easiest to get in and out of, and also carry a folding wheelchair? I personally do not have any experience with that. I know Cars like an SUV can be problematic because they're so high and the person has a hard time stepping up. So that I would say more like a sedan. A lot of times people find it easier to get into the back seat versus the front seat. Opening the door and having them transfer, if they're in a wheelchair, transfer. So a stand, pivot, and sit, and a lot of times they end up lying across the back seat, so somebody has to go around to the other side and help them actually sit up. But I think cars that are not so high off the ground generally are easier to get into and out of when motor control is a problem.
Thank you so much, Sue. So we are at the 4-minute mark right now. We have 4 more minutes left. So if you do have questions, please send them in. As a reminder, to send in a question, all you have to do is go to your question panel, type in a question, and press send.
Okay, Jane, thank you. I'm going to just look here. There's a question, what strategies would you use to help late-stage patients initiate opening and closing mouth for eating or swallowing? This is it's a common problem in late stage, and it's very, very difficult for these folks to open and close their mouth. Again, without seeing the person, it's very hard to make any kind of generalization. Oftentimes a speech pathologist would come into the picture, and I've seen speech pathologists use some massage at the jaw, especially if the reason that the person is having difficulty opening and closing is due to a lot of rigidity. It may mean that the person also needs medication to help, like a muscle-type relaxing medication that helps to reduce some of that rigidity. But without knowing exactly what the reason for the difficulty opening and closing, it's hard for me to say. But definitely a speech pathologist should be able to assist with that kind of problem. Any suggestions on when a person should stop driving? This is a very emotionally charged question because very often family members want the person to stop driving well before the person recognizes the need to stop driving. And I think the answer really is to get an outside opinion. There are rehab facilities that offer driving tests. Some departments of motor vehicle also offer driving tests, and that's really what the easiest way for a person to accept the inability to no longer drive is to have an outside person or an outside agency make that determination. It's very difficult if it's for if it's a family member that's trying to tell them to stop driving. Then they're just not going to listen because, let's face it, every husband and wife have had this argument. So it's important to try to get someone from the outside to determine that. And it's even better if you can get an objective view, like a driving exam at a rehab facility.
Thank you so much, Sue. So unfortunately, we are out of time today, but thank you, everybody, for attending, and thank you to Lundbeck for making the Caregivers Corner webinars possible. And you can view this webinar and all of our webinars in the future just by going to the Living with HD section on the HDSA website.
Thank you very much, Jane. I appreciate the invitation.